Good morning, everyone. Welcome to Cardiology Grand Rounds. Gives me great pleasure today to introduce Dr. Tariq Ahmad. He is the Chief of Heart Failure at Yale, and he did his initial training at Harvard Medical School and then went on to Duke to do his cardiology training and advanced heart failure training. He's really, paved the way for multiple implementation clinical trials and pragmatic clinical trials across the Yale system in trying to help us answer some of the questions in practice of heart failure. So we look forward to learning these from him and hopefully doing some of these over here from what we learned from you. Welcome.
Dr. Goh, thank you so much for the kind invitation. And as someone who ran Grand Rounds for several years, I know it takes a lot of work. And what I experienced here in terms of the hospitality and just the organization is unsurpassed. So, really, really appreciate you having me here. It's truly an honor. So the first disclosure that I have was that this is a very different talk than what I had on Tuesday night. I was going to talk about, creating a learning healthcare system, but then on Tuesday night I sat down and I'm like, this is really boring. We should make it a little bit more interesting and more personal. So I'll talk a little bit about my journey as an academic heart failure doctor, put myself out there. I may fall flat on my face, but that's what happens when you take risk. These are my disclosures. So my first disclosure is why I decided to do heart failure. And there's two people responsible for that decision. That's it. It's Ken Baughman and Joe Rogers, who's sitting right here. If my kids decided to make decisions the way I did, I would yell at them. I just wanted to be like Joe and Ken. So I now have someone to blame during any, psychiatric sessions or anything in the future. So, but Joe, thank you for being here. It's a real honor because I've really looked up to you my entire training. So, and you're the reason why I chose this. So, I've really been struggling with what it means to be a heart failure doctor. I've been, in my job for about 8 years after training, and it's been confusing to say the least. I look around me and the EP doctors and the imaging doctors and, the interventionalists, they have a very clear understanding of what their job is. But for heart failure, it seems like it's, there's no clear kind of discussion about what we're just bouncing around different subspecialties. Like one patient may involve EP, so we have to know quite a lot of EP. We have critical care patients, we have cardio-oncology patients, HCM. It's all over the spectrum, so no one can really has been able to tell me what it means to have my role. So what they say in self-discovery is to start off by knowing thyself. And that's something that I did at Yale a few years back. We created a live registry of every single heart failure patient in our system. It updates every few days, and it has all the information you would want for an individual heart failure patient, what meds they're on, what readmission rates are. I mean, this is granular at the level of the patient, so we know in each kind of county of Connecticut what the quality is like, what medications they're on. So really trying to understand who are these patients that we're responsible for. And this was all luck, but when we looked at our data compared to the data nationally, for whatever reason, Connecticut is a good snapshot of the United States because we have the demographics that are very similar to the rest of the US. And when we looked at our data compared to the CHAMP-HF registry, the demographics were very similar to, and so, no one has ever accused of people from Yale being, having, like holding back. So I'll say what happens at Yale reflects the country in general. I first started off with, well, maybe the role of the heart failure doctor is to understand and communicate the journey, right? We take care of patients across the spectrum of disease. We meet them in clinic. We see them in the hospital. Sometimes they're not doing well, and sometimes they get a transplant. So we're with them across their journey, and maybe that's something that is a role of the heart failure doctor. And as a fellow, I really, got into this. Like, what is it that we can add to heart failure patients' care? And I came up with, maybe we need to be a little bit more data-driven, because just the syndrome of heart failure is so poorly defined. And the key insight that I had at that time was that data that is objective can help us get better at being able to understand heart failure, because it's a complex disease and it's poorly defined. The other thing that along those lines that we were able to do, and other people have done this as well, is that we really needed to move away from these arbitrary cut points of ejection fraction. We know that EF is not a good way to define this syndrome. We showed that, other people showed that. Now the NYHA class, for example, for those of you who don't know, has been around for more than 100 years. And it's a really poor way to describe heart failure. It's not precise, it's not accurate, it's all over the place, but it's still done. And then this is the only time that that someone got upset at me at an AHA presentation, because for whatever reason, the bedside hemodynamics, the cold, wet, warm, dry, is to heart failure clinicians close to religion. So if you say something that, maybe this is not accurate, they will get very upset. But what we found was that a data-driven approach was much superior to these classifications of cold, wet, warm, dry. So what I'm getting at, I'm not the only one who's done that. If you do a PubMed search, there are thousands of papers on prognostication in heart failure. And if you distill everything down, the bottom line is that we can use data to predict outcomes in heart failure much, much better than these classifications that we use clinically. And that's it. So the favorite thing, at least when I was training for heart failure researchers to do, was to make a risk score, right? And every other week you would see a new risk score on heart failure. So a central paradigm in heart failure, and this was assumed, is that if you're able to predict outcomes in heart failure, you will automatically do the right thing and patient care will be better. This is something that even today, as a journal editor, I'll get papers on this that assume this, that if you can predict outcomes better in heart failure, somehow we will get better outcomes. And so we tested this at Yale. We designed the REVEAL-HF clinical trial. We came up with a risk score based on our cohort that essentially mirrors a lot of stuff that's out there in the literature. It was very accurate and very precise in one-year mortality prediction. And we tested the hypothesis. So this was a pragmatic, randomized trial, so that any person with acute heart failure that met certain criteria, they needed IV diuretics within the first 24 hours. If they had an NT-proBNP more than 500, they were enrolled in the study, so it wasn't consented because it's considered minimal risk. And the clinicians who were randomized to the alert, so if Arvind's randomized to the alert and he's putting in orders, it would say, Mr. Jones has a one-year mortality of 60%, right? Just that information, and we made a graphic that shows you what it is. So down the line with that patient, like their clinicians would get that information. And if you ask me to bet, I would say it'll help with outcomes, you'll do the right thing more, you'll get more engaged. And nothing. Absolutely nothing. Like it made zero difference on any outcomes, 30-day readmissions, one-year mortality, and the mortality rates were pretty high in this patient population. If you look at, it's like 28%. So these are sick patients. Nothing, no difference on inpatient mortality, one-year mortality. And the interesting thing was it made absolutely no difference in clinical decision making either, right? So everyone was just like, okay, 60% mortality of death, so what? And that led me to lesson number one, which is that as heart failure clinicians, we've focused so much on inaccurate descriptors of disease progression and less on treatment pathways that are rooted in data-driven assessments of risk. So when I asked people, like, well, why didn't you do anything different? They told me, well, there is no recommendation in heart failure that's based on risk. So when Dr. Guha is recommending a defibrillator for his patient, it's not based on risk. Like, if the patient says, what's my risk of death in 5 years? You'll say, well, you have a low EF and you have NYHA class 2, you need a defibrillator, right? So we've really done a disservice by not getting granular in heart failure the way that we have in other complex diseases. So in that regard, that was one of the lessons that I learned, that this is something we need to do a lot better with. We're not doing a good job, and we're still kind of sticking with our NYHA class and EF cut points and things that are inaccurate. So then I thought, well, maybe our role is to get people on guideline-directed medical therapy, right? If you go on med Twitter, that's what most people are screaming about. And expensive, human capital interventions have not really helped. They've done large trials that have shown that, all these kind of infrastructures that we've put into place to get people on GDMT really don't do anything. I mean, if you can, put like a pharmacist looking at every single patient, you can do that, but is it scalable? Probably not. So we designed the PROMPT trials. These were 2 trials, one in the inpatient setting and one in the outpatient setting. The EHR nudge that we used, I'll spend a little bit of time on this because this is important, is that in the outpatient setting, if you saw a patient who had a low ejection fraction and who met the criteria, who was not on all classes of GDMT, the clinician would get this alert when they're putting in orders. And it would show you all the variables that you need when you're making a decision about GDMT, so blood pressure, heart rate, creatinine. It would tell you, these are the meds the patient's on, these are the meds they should be on, and then here's an order set to put them on these meds. So made it very, very easy for the clinician, right? So this was the outpatient study, and this was done really rapidly. I mean, the thing about these trials are that you can randomize like 1,400 patients in like 8 months. So we were able to do that, and the primary outcome showed that GDMT increased, right? So the number needed to alert was only 14. And the number needed to alert for a higher dose plus increasing GDMT was about 10. This was presented at Late Breaker. People give us a lot of kudos for it. But I'll get back to why I'm less bullish on this. So we did the same study in the acute heart failure setting. So let's take the same patient population, do it in the acute heart failure setting, enrolled a lot of people. It was very similar to the patient population in Pioneer HF, so good acute HFrEF population. And when we looked at the primary endpoint, nothing. It made absolutely no difference in what happened. And if you looked at the dose, the class, it really didn't change anything. And this was interesting. So if you looked at the guideline-directed medical therapy at baseline and discharge, it went up a little bit at discharge, but really did not change what happened much in terms of the guideline-directed medical therapy usage. So right after I presented the first study, I was getting all these kudos, but then one of my research mentors, Adrian Hernandez at Duke, texted me. He's like, well, you seem to have fixed the issue for 10% of the patients, but what about for the 90% of the patients, right? I mean, it was his way of needling me, but he's right. I think what I've learned from these experiences is that if we leave this decision-making to clinicians, there is way too much noise for us to achieve what we want. People, at the end of the day, are going to, do things, not put people on medication for a variety of reasons that are personal, like if it's, laziness, or is it, their last patient, they're not going to be able to fill. There's a lot of different reasons. My perspective has been, after going through this experience, is that we need to automate this the stuff that can be done in a very regimented manner. It should be moved outside of what clinicians are responsible for, and make it as easy as possible. I mean, maybe you just say, you get routed all the orders and you say yes, but the individual act of putting patients on this needs to be taken away from, I think, human beings for the most part. And where there's a lot of companies working on this, I think that it is the future. But we've been doing this for a very long time without much success. So I don't know what other, lesson you would learn from our experience thus far. We can't wait for a decade after a medication comes to market for patients to get on it. I mean, it just doesn't make sense. So then I said, well, maybe, our role is to be VAD and LVAD cardiologists. I mean, that seems like a safe bet, right? Like, that's something that a lot of us went into cardiology for, and it generates a lot of news. Like, this one was interesting where, Hopkins performs 5 transplants in 7 days, 4 transplants in 8 days. Like, it's just every little part of transplant seems to get out in the news. And, clinicians like that recognition. They're tweeting about how many Impellas they put in, or VADs, or transplants. It's a very, I'm sorry about the colloquialism, but almost a cool way of describing our job. Now, certainly the number of transplants are going up quite a bit, right? So that's not a problem, but LVAD use is going down. That's something we all know. And someone told me that, treating heart failure with transplant and VAD is like treating poverty with a lottery. It's great, but even high functioning centers are going to do maybe 50 transplants, and that's not the burden of disease. We're not going to cure heart failure with VAD and transplants. So heart failure doctors could just say, okay, we're just going to do transplant and VAD and just get away from everything. But I don't think that from a philosophical point of view, it makes a lot of sense. Like, you have to kind of cover that entire population, right? So I looked at the ABIM and how many people are certified in what we call advanced heart failure and cardiac transplantation, which is the specialty. And if you were to have a ratio of the number of people trained for this and the number of transplants in a year, I think it's like 1 to 2. There's like 1 advanced heart failure cardiologist for every 2 or 3 transplants, which I would think is probably too much. So do we really need to have so many advanced heart? I mean, we're training all these people primarily in transplant now. But are there enough transplants to go around? At least in our center and other centers that I've looked at, you have 1, 2 fellows, maybe even 3 fellows, and they spent the vast majority of their time learning how to do transplant. But again, the majority of those people are not going to be transplant cardiologists, right? Are we really kind of training the army that we need? And for a lot of the people that are getting into heart failure, I think we have to be honest. Are you going to be a transplant cardiologist or not? And for a majority of them, it might be no. So this is a little bit, interesting because I've thought a lot about this. So one thing that we could do is guide heart failure research. Now, I think the heart failure population has the highest mortality rate out of probably any subset in cardiology. So you have a lot of delta you can move, right? ACS trials have to have 30,000 people to show a benefit. Heart failure trials less so. So there's a lot you can do. We have a lot of heart failure publications. I mean, it's exponential. We have a lot of heart failure journals. But heart failure mortality hasn't changed much. It's really kind of, I don't know if this data is correct, but Marat Fadim just, published this, which is getting a lot of play, that heart failure mortality went down a little bit, but now it's back up. So whatever it is that we're publishing, it's really not changing the patient outcomes. And I lived a little bit through this. So when I was a fellow, I saw, there was a onslaught of studies from the NHLBI-funded heart failure networks, all negative. And it really made me think about, well, we're testing hypotheses that we believe to be true. How could it be that every one of them is negative, right? Now, you could say, well, there's all these reasons why these trials are negative, or you could just say that maybe your paradigms are incorrect. We've had negative trials for inotropes. We've had negative trials for a variety of heart failure, novel heart failure therapeutics. We've had negative trials for strategies, right? What's the reason for that? Like, are we really kind of questioning the basics of what it is that we're doing? Because that essentially is when paradigms change, right? Like, you keep doing the same thing over and over again, expecting a different result. And at least I feel that we've been there for a decent amount of time. So, and again, this is my editorial comment. I think, having at least been on the editorial board of one journal, I've found that most of heart failure research is kind of low value. It's low risk, low reward. It's kind of just repeating things that have already been done. And it's building on flawed paradigms. No one's really kind of pushed at what it is that we're testing. And then there's heavily influenced by industry. There is a subset of thought leaders in cardiology where most of the research, especially the secondary papers that come out of trials, are what industry would want you to say, right? So, which is why you see a lot of tweets about GDMT, but I don't remember seeing a tweet about, prevention or exercise or anything like that. So there is a move towards essentially doing the kind of research that, pharma is interested in, and that's really something to think about. So I'm sure I'm not the first person who showed this slide here, but at least from my perspective, I feel that we have a little bit of a problem in heart failure, and through my relatively short journey, I've come up with a true question about what is it that we stand for and what do we need to do to change. So, lots of us love complaining, but I'll leave you with a few next steps. And by no means am I, this is something that we'll all have to do together as heart failure clinicians. If we first of all think that there's a problem that we need to change, and if we can even do this. So first of all, I think we need to create the army that we need, right? I don't think that we need to keep training so many transplant cardiologists, given the numbers. And that's reflected in the numbers of people matching for advanced heart failure. I think half the slots are not taken. I think trainees have figured out that, if I'm going to spend another year doing training and not have a job doing what I trained to do, that's a problem. And I think we really need to modify the training pathways to make it so that the cardiologists that we're training are comfortable with taking care of amyloid, pulmonary hypertension, all the complex diseases that we need. And I think what's happened is a lot of those people who were interested in heart failure have ended up doing critical care cardiology, which is this new, and in their roles are much more defined. They're in the ICU and that's it. And I think that's a little unfortunate because these people are the clinicians that you need to also see patients in clinic and otherwise, because they're really, they're very good doctors. So the other thing that I think is an important role is, and this differs across different centers, right? There may be some centers that have a lot of very good clinical cardiologists, and then some centers where the heart failure doctors have essentially become the doctor's doctor, right? Like if you have a very complex valve disease patient, or you have pulmonary hypertension, or you have infiltrative cardiomyopathy, if you have all those cases that would be worthy of a case report, like that's where you go to the heart failure cardiologist. So they're the kind of the macro economists, the macro cardiologists of our day at many centers. And I think that we have to embrace that, and we have to get trained for that. We can adapt to it, but I think that that's something in the future that we need to train people for. If you don't have someone like that at an institution, then a patient becomes a VT ablation or a tricuspid regurg, and you go away from the holistic aspect of patient care that I think is central to good medicine. And that's something we're really getting away from in this world that's getting highly subspecialized. This is also, it's complicated, right? In this, we had long discussions last night about, RVUs and pushes to productivity and things like that, and the struggle between quality and value has been something that I've heard long about, and I don't think anyone has a good answer. But I think if we do want to have the best kind of patient care, we have to involve the heart failure doctors, because otherwise there'll be less thoughtfulness around using these expensive, highly invasive interventions. So if it's the MitraClip or is it an Impella, I think that it is important for us to get involved in those decisions. We've seen that with shock, but it varies across systems, right? Like we have to be thoughtful about who we're putting these expensive devices in. Are they really getting benefit from that? And somewhat divorce the decision from the people who are responsible for doing the intervention. I think that's very important. And people have talked about team-based approaches to valve disease and other things, but I really do think that heart failure doctors have the perspective that's important to have a seat at this table. This kind of intervention that I was somewhat proud of, I kind of convinced Beacom to let me do this, was to create a au contraire section at Jack Heart Failure, where we encourage you to submit write-ups that question basic premises in heart failure. It really has not existed before. There have been few venues for people to express things, and for the most part, the people expressing it are very, very senior. But I wanted something for everyone, like people who are on the front lines, to write something about what they feel are the big challenges in heart failure, and question the major assumptions. Like that's the only way that we're going to change internally. If we really put that out there in terms of, is this something that's worthy of us still holding on to? And it could be anything. So if any of you please have an interest, submit something. We've had very good submissions already. Provocative, the first one is going to be a provocative piece on hospital at home. So would love submissions from fellows, faculty, anything that would work. And then this is something that was very difficult to do at Yale, creating a learning healthcare system, because for us, each healthcare system, the people that are responsible for the health records or the EHR are very different from the clinicians, and there's going to be difficulty in convincing them that we need to be able to, do clinical trials and everything that we do. So when you think about how much data you generate at just this hospital, that's probably 100 insights a day. Should we be putting patients on this diet? Do we need to keep patients NPO overnight? Like, these are all things that we should be able to answer with very simple, pragmatic, randomized trials within the healthcare system. And after, and you had asked that question as to like how we were able to do that, the biggest difficulty was convincing the leadership to let us do it. Doing it was very easy. There's obviously concerns that for the most part are exaggerated about, data will get out or things like that. But doing the randomized controlled trials within EPIC is relatively easy. You just have to have buy-in from leadership, and then somehow convince them that it does provide value. So it's very doable, and you could scale it to answer all sorts of questions across the healthcare system. And I wanted to end with this sooner than I thought, but this kind of brings me back to the journey that I've been on. What is it that my role is? And this is something that my grandfather wrote in 1950, and he was a surgeon, and but he still saw himself as a doctor. And he articulated that, and this, I really like this line, that every man who's born has to die, and if death is to come, and he was in Pakistan, should be told quite plainly, and nothing can be done to save him. To advise costly treatment and travel is heartless. And I think those are the issues that have persisted across history of medicine, right? We've always had people who have advanced disease, who are going to pass away, and we've always had clinicians who are trying to save them. You've had interventions that have sometimes hurt patients, and sometimes have helped patients, but the first instinct has to be patient-centered and not centered towards a certain intervention or a certain device. And I think in that way, my grandfather passed away when I was very young, but I saw that in Joe as well, which made me want to do this, because I felt that it was very close to what I felt a doctor's supposed to be. And I think those are the challenges that we have in heart failure. We have the sickest population of patients, and we have people who really, really care about the individual patient. It's hard work, and it's emotionally exhausting. But I don't think I would do anything else. And obviously, I showed you all the challenges that we have. And hopefully in the next 10, 20 years, we can play a role in addressing those challenges. So thank you very much. Really honored for being here.
Thank you so much, Tariq. That was thought-provoking. A lot of things for us to think about and do in the next 10, 20 years, as you said. So we're open for questions.
Era of heart failure that in the last decade we've seen in the evolution of advanced therapies and redefining. And I mean, I didn't think about it the way you portrayed it, but our program went through the evolution because historically we were an advanced heart failure program just on VADs and transplants. And then we spread the scope to a point where, as we were talking yesterday, every complex patient would end up on your service, and then you start resisting it because you're figuring out what your role is. But you brought up a good point on embracing that aspect and embracing the concept that we are broad physicians and that macroeconomists. But the challenge, I guess, that you alluded to at the end, and I don't know what your thoughts are, you have a forum in the journal to invade to the community, is we talked a lot on RVUs, which I think are a good measure of productivity. But the question becomes on how do you define and measure productivity? Because as you mentioned, sitting and holding a patient's hand, talking about death and VAD and transplant and that complex decision making is not valued into the productivity concept, right? So it's a service. I feel like the field of medicine has evolved to a point that it's got more complex than how it was 20 years ago. So there's no E&M services. So how do you think the field should approach in defining these little bit of a fluid concepts on giving value to the time that is invested and the complexity of decision making?
I mean, that's such an important question, and that's something that I'll right off the bat tell you I don't have the answer for that. You know, I think that it's very important for us to resuscitate the soul of medicine, right? Because there's going to be a push towards making it a business. You know, we don't work at Goldman Sachs, we work with human beings. And we're going to have to figure out ways to resist it. Otherwise, you know, it is going to be caustic to our souls, and eventually we'll be unhappy. And, you know, at least people who went into this for the human aspects of it, and will feel that we're very far away from our mission. And at least in as I've gone from training where I was protected from all this. I never thought about this when I was training. I wish I had, you know, I didn't even know how to like do billing, you know, like I didn't know what an RVU was. It's the real world, but we still have a leadership role in society, and I think it's important for us to articulate that. Otherwise, you know, it's going to be an important institution that will fail. So I mean that gets to the heart of this existential threat that we have in medicine.
Well, thank you for coming, and I'm glad you pivoted on Tuesday to talk about this topic because it shows the depth of your wisdom and your introspection about a field that, at least to me, looks like a bit stuck. And so a comment and a question. The comment, and I do hope that this institution and other institutions use EHR nowadays to do randomization on things that may not necessarily affect patients negatively, but at least a decision-making would help you to see what the outcomes are like. And I know different IRBs look at it differently, but you know, this is what's being done. And I think the more you publish and you put it, you know, particularly for heart failure, the more you publish in JACC Heart Failure and other journals, I think people would embrace it more and more, and there is something that people could rely on. The other question was, I'm interested in this, the trial that you did in your own hospital, in the acute and the other setting, particularly in the acute setting. The 4 pillars are of different length of GDMT. And the question is it resistance? I mean, you're giving these individuals, the team, all what they need to make a decision, all right? Besides simplifying it, said yes. Is it resistance? Is this medical contraindication? What is it that is the, you know, stumbling block? And on the other hand is the outcome, I mean, I'm questioning now, is the outcome of patients when they come in with acute heart failure who are on all the 4 pillars as opposed to the others, is their outcome any different? Because you've challenged us that at times, although we think, you know, we're doing a good job, the outcomes may not be different.
So that's an excellent question, and I'm so glad you brought that up. So, you know, my wife is a behavioral economist, and she works at a business school, and they do these studies all the time, and I'm surprised why we don't do more of this in medicine. Um, and I'll give you an example. So they started reporting out, showing on the menus in New York City the calories for fast food, right? And everyone figured out, oh, this is going to lead to people making better choices and get thinner and all that stuff. Nothing happened. People were still ordering the high calorie, like the McDonald's, 1,500 calorie meals. It's counterintuitive. I think human beings are complex. As to why in the inpatient setting they didn't start people on GDMT, I suspect there's too much stuff going on, and they think someone else, as long as you think someone else is going to do it, you don't want to deal with it, right? So they said, okay, it'll be done as an outpatient, follow up in 7 days, someone will take care of it. And there's a lot of stuff going on in the patient side. You're getting like alerts about like sepsis or like, this person has restraints or whatever it is, and it's overwhelming and you don't want to deal with it. I suspect that's the reason. Is in terms of like I think people who are on pillars of GDMT versus those who are not, you're comparing apples to oranges, like the people who can tolerate all those meds, they don't have renal dysfunction, they don't have other, they're a very different phenotype than someone who can't tolerate it. I would say that probably there's a very significant percentage of people who are not on meds that they should have been on. Like an SGLT2 inhibitor is pretty low risk. It's just people will defer to the outpatient setting or somewhere where they're not responsible. That's my take on it, but it's something that, to your point, we really do need to study everything. Like, we're generating the data, so might as well study it, right? You could do low risk randomized controlled trials here that would answer foundational questions about heart failure and stuff that matters to patients, right? Like something like, there's no data for low salt diets in the hospital. Like, why do we do that to patients, right? We can just randomize to regular versus, like, there's a lot of stuff that we do to patients that is, not data driven, that we can test very rapidly and have an answer. Yes, sir.
Thank you very much for a very thoughtful talk. I loved it. A couple of questions. One is, you suggested that some sort of automated algorithm perhaps would be superior to letting every doctor make their own kind of decision. But has that hypothesis been tested? Is there a randomized trial where we have patients cared by an algorithm and the other group by the doctors and see what happens? That's number one.
That's a really good question. There's a lot of companies that are suggesting that. Okay. They want to come into health systems and do it. I think the tricky thing is that you will have to get rid of some of the human beings in healthcare systems. And
absolutely.
It's very difficult to
yes, sir.
downsize in the healthcare system.
Yeah, it clearly would be a tough trial to do, but I think that's in a way the gist of the question that you're suggesting. Now, the second question is more in terms of trying to get deeper into understanding this better. Even high-risk patients, not everybody dies.
Yep.
And then we have this guy that should have died 3 years ago, and he's still around, comes in with the daughter or family. They still go to the movies and take vacation. So can we learn something by being more in-depth studying the survivors? Is there a signal there that we could learn from?
Absolutely. I think we should have, really, I completely agree with you. There's probably some biological thing, there's probably some mental aspects of it. That's a fascinating thing that we should study, like the survivors of hospitalizations. I mean, I'm not aware of anyone who's done that. I think it'd be really important to do. That's, actually got texted by one of my colleagues who Dr. Rogers knows as well, Mark Samsky, and he's like, sending me pictures of this patient that I think all of us thought would not be here, and he's walking around. So it happens all the time, but it's something that we study the sick people. We don't study kind of the other outliers. Absolutely. And Dr. Zogby, to your point, the randomized trial coding that we've created, we've made it readily available to anyone. So we sent a write-up along with the code to other centers that wanted to do this. So it's being done at Inova, it's being done at University of Colorado, it's being done at Northwestern. So, it's basically like created if you can convince the leadership to do it, it should be pretty easy to implement.
So thank you for this talk. When we see some of these data from your group as well as others, there appears to be a difference perhaps in some of the outcomes we see in the acute heart failure setting versus the outpatient heart failure setting. And one of the challenges that we see in heart failure is it's such a high risk condition. And so I wonder your thoughts on, once you reach a certain level of risk, a certain threshold, it seems as if we should be extremely aggressive in all of them. And although there is still a gradient, my questions relate to, is there an upper bound of risk where we actually should be thinking about, like you had mentioned, perhaps we need to refocus our goals as to what we're doing for those very, very high risk individuals? Would these therapies even work, as we've seen that some of these pharmacotherapies may not actually work in some of these more advanced settings? And then when we see this gradient of risk, actually one of the classic situations we see this is with statins for prevention. Yeah. And so when we think about heart failure prevention, something our group's thought about a lot, is this an area where you think we should be doing these types of risk-based approaches to guide therapies, because there's such a broad gradient, it's a stable setting, and how would you design an intervention like that in a pragmatic way like you guys have done in these acute settings?
That's a really, really important question. So we have shied away from using risk as a way to get people into trials. I think that that's a big mistake. Like, we should be putting people into studies based on certain risk profiles. Now, I'm not aware of anyone who's done that. I've tried to convince companies to do it. I think if they've done it with omecamtiv, they may have had a successful result, but there's always a push-pull between like trying to get people into studies and doing that. So I don't know why we haven't done that for defibrillator studies and other things like that. The caveat is that the biggest predictor of risk in a lot of cases is age, right? So if you're like 85 years old, you're going to have a very high risk, and then the interventions for you are going to be very different from someone who's 50. So I think we need to take that into account when we're making decisions, but absolutely agree with you that we have the risk scores that can give you a reasonably good predictive ability. I don't know why we don't use them to get people into studies. We use things like NT-proBNP, which, it's better than nothing, but it's still not as accurate and precise as using the full complement of parameters. But I think in preventive literature, they've done a much better job of risk stratifying. So the statin data is amazing. The less risk you are, the more benefit you get, and then it kind of goes down. I don't know what the data is for SGLT2 inhibitors and ARNIs and things like that. I will tell you that as long as they're, that they're not generic, the pharma company will not want you to do that study because it will take away their market share. And there is some signal that people with advanced heart failure do worse with Entresto. So I'm going to joke about this, that I probably take more people off Entresto than put on it. But, I think that's a little bit, there's not great data around that.
I'm Ron Yusuf, one of the heart failure transplant cardiologists. I just want to get your thoughts as you touched base on the level of the trainee and training. So what should we do? Because as you know, as more people are coming and less people are interested going because of all these challenges that you mentioned. So should we separate, in the level of trainee, a transplant cardiologist versus a heart failure cardiologist? Should we decrease number of the spots, or or because when I can tell you, like when I was interviewing after a fellowship, there's a few jobs I went there. There was this, hospital, they didn't have a VAD or transplant in, but they have a heart failure position, and my job was to convince everybody that they're gonna need me, and they refer their patients to me. So how should we approach this? What we should tell our trainees about this?
I mean, I think that's a very complicated question, right? I'm not sure what the politics were of creating the ABIM. I mean, I know there's seniors here who might have played a role in this, but I think that supposing you're a fellow, right, and you come to Houston Methodist, we're doing a lot of transplants here, and whether you like it or not, you provide labor to, the group here. So it's good. They won't be terribly happy if you're there in HCM clinic for 2 months, right? They want you doing biopsies and things like that here. So there's a huge kind of conflict in terms of what the needs are of the training center and what's best for the trainees. I think it has to be done in a global manner. Like, do we really need this many slots, and maybe decrease them, or change it so that it's not transplant VAD. It is something like adult congenital, where you have you do pulmonary hypertension, you do HCM, you do amyloid, you do everything that makes you be able to be much more flexible in the kind of job that you do. I don't have the great answer for this, but I have to tell you that there is a massive need at this time to pivot and have a very different kind of training pathway for people who want to do advanced heart failure.
Thanks so much for, I think, sparking a lot of thoughtful reflection of everybody, I think, a little bit. I think one of the things, and I really appreciate what you said, and I truly, unfortunately, believe that we've really become a conveyor belt industry. Patients come in, they ride the conveyor belt through various places, and they go out on the other end. And they may or may not get stopped along the way, because that slows down the conveyor belt. And if you slow down the conveyor belt, then people get unhappy with you, either waiting on the outside or the manager upstairs. I think we talked a lot about, focusing on, like you said, of what we offer to patients. But I also would love to hear your thoughts about, as far as like therapies, and you prescribe stuff. But I think that there also should be a focus on what we spend time talking with patients about and educating patients. Because I think one of the things that you pointed out, and I know that a lot of us have seen this, especially heart failure doctors, when they come in and they've been in the hospital, 6 times with heart failure, and no one has told them that they're dying. No one has told them that your life expectancy is X. Or even better yet, when we prescribe these 4 medications, no one has told them why that they're prescribed these medications or what they're doing. And if I'm as you pointed out, a 65-year-old African-American female in rural Louisiana who's trying to take care of my grandchildren and get them to school every day, and figuring out if I'm going to put money on the table for their food or buy this medication, and nobody tells me why I need to do it, it's an easy choice for me to make of what's going to happen. And so do you think that there needs to be almost a metric? We have a metric of GDMT, we have a metric of ICD. Should we have a metric that's patient-centric? And how would we look at that?
I mean, that's a really, really good question. One of my colleagues, Larry Allen, has done good work on that at Colorado, where he's, come up with scripts for patients and having patients more engaged in this. He did a study where before they see a physician, they get information about medical therapies. They should ask their physician about it. I agree with you. I think we do a terrible job. I mean, that's where the soul of what we do comes into play. If I'm told I have 20 minutes to see a complex patient, it's very difficult to have those conversations, but at the same time, it's not efficient if I spend more time with them. And I don't have an answer to that. I mean, that's one of the big struggles that I have. And I think the next generation of patients might just get sick of us and go somewhere else if we don't do a better job with this. There are lots of online, ways for people to get healthcare now, and there will be some disruptive innovation that comes up that bypasses, this institution if we don't provide true patient-centered care. And I think that's something that will be down the line unless we modify our behavior.
Just one last question, just continuation of what Cindy said. So with your alerts that, the EPIC trials, have you tried anything where you just send the message to the patient, telling them that, look, you're at this much high risk, you should go see an advanced heart failure, whatever it may be. Or you should be on these 4 medications, ask your doctor about it. I mean. So
that gets a little complicated because the IRB did not allow us to do that because they felt that it would cause like emotional issues if you send something directly to patients. So we would have to consent them, and then it just gets incredibly complicated in terms of sending someone information and like that they don't know how to deal with. But I mean, I think that is a more complicated study that we should do. The other thing that it gets complicated if you quote unquote message a patient directly is that at least in our healthcare system, you will upset their physicians if you bypass them. So there are, all these like issues that come up with, with how we've set up that, there's so many battles you can fight. And, I've been called to the principal office enough, like I don't, this would be another reason for me to do so, but I really do think we need to get patients more and not treat patients as people who don't really know what's going on. Like I think we should be a lot more honest and transparent. I don't know if it happens here, but patients can read all their charts now at Yale. So I will get questions on like why did you say this about me and things like that. So I try to like write all that information down in the note. I basically write my notes so that the patient's going to read it. Which.
Thank you. Tariq, I think I just wanted to hit on the last part that Ash brought up on patient engagement. And as you're evolving, I can see you lead some of these into the patient realm. 2 points I wanted to make is one, I feel some of these statistics are made to validate our existence about 5-year mortality because we're always trying to tell somebody that our field is important. But when patients go and read these, they're devastated. Like
yes.
I have patients who show up in my office saying in their EF is improved, their blood pressure is high, they can go on med, but they're like devastated until you sit and counsel them. So there's this balance of how do you morph it, but I also feel we should, if we're opening that area of patient engagement, we need to question on how these statistics are being used across, like globally in Google, and what is objective of it. And then my second comment I want to make is that, we've done quite a bit here in patient engagement in almost, I call it a parallel universe of creating conferences for patients. And in my experience, I've realized that patients really want to have that information. And by creating a paradigm where you can empower them.
Yep.
But then the limitation is I've tried to advocate through HFSA to create a billing code for education, and there's no investment at this stage. So as we're moving towards patient engagement and empowerment, I think these aspects might be important for sustainable change. So hopefully that can be incorporated into your efforts.
It's like you're a true leader in this aspect as well. We should keep pushing and trying to get the societies engaged in making the changes that we think should be made, because obviously there are corporate interests that are driving a lot of the movement, the current kind of movements that we see, and we have to counter some of those. So what you're doing is incredibly important. I think we should get the societies to push harder for this intervention. Absolutely.
Thank you so much.
Thanks.